Thank you. My name is Fanny Louvet de Verchire, and I'm the Chief Product and Marketing Officer for Ultrasense. We're developing AI for oncology follow-up, ultimately aiming at completely streamlining the RECIST and treatment response.
Hi, I'm Chris Mckee. I'm the Managing Director for the UK at Better Medicine. Our company focuses predominantly on abdominal AI. In particular, kidney cancer is one of our specialty areas that we've brought to the market. But we also build solutions for automating RECIST workflows and lesion management and lesion segmentation tools, which you can use across not just the abdomen, but the chest as well. So we're really trying to go for full body holistic solutions. We have a particular focus on bringing AI solutions to the abdomen first. And so I think it's going to be a really good conversation today about where the AI space is moving in terms of the abdomen.
Great. So the most important question of the whole RSNA, right? We all have stroke detection algorithms, lung nodule detection algorithms, breast cancer detection algorithms. Everybody has them. Why don't we have more abdominal imaging algorithms? Please.
So for
both of you.
Yeah. So it's a really interesting point. I would say a lot of it happened simply because of the demand for example, lung, breast, and prostate AIs, which have been a kind of a heavy hitter, obvious sort of low-hanging fruit opportunity for AI companies to start with. So that it just makes sense why people would start there first. There's a high demand for it. There's a global demand for it. Lots of screening programs. It seemed like a place where you can generate revenue as quickly as possible. That might not necessarily have been true, but that's where people saw the opportunity. But what we're starting to find now is those AIs, whilst they do perform very, very well, they're limited in terms of their use case. It's sort of almost one-trick pony in some ways. And people are now starting to think, okay, well, what about all the other types of cancers? What, maybe not the top 3 cancers, but what about cancer number 4, number 5, number 6 in terms of incidence rates? Can we really neglect our patients who do not have lung cancer, but they have kidney cancer, or they have liver cancer or liver mets? So that I think the market is now moving much more towards, okay, well, there's other opportunities in the AI space. The abdomen is really underserved. There's almost a gold mine of opportunity there for AI companies to take advantage of. And we need to make sure that we don't end up with almost a 2-tiered medical system where like some people will be able to be treated and diagnosed with AI because they have lung cancer or breast cancer, and then everybody else doesn't have AI. So this is, I think, where people are starting to wake up to this. Radiologists are starting to demand more of this. And actually the use case may even be different to, let's say, lung nodule detection. It might be for incidental findings, opportunistic screening, which we can talk about more today. So that's my view on this, Leon.
Yeah, I completely echo what you just said. So basically, artificial intelligence for only what you have trained the algorithm for. So basically, when you're entering a new space, a new industry, AI is really good for a specific task. So in imaging specifically, it really makes sense to start with, as you said, kind of the lower hanging fruit, even if it brings a lot of clinical value, obviously. X-rays, CT scans for screening, which are, the protocols are very standard. There is not a lot of variability. And also the use cases are kind of boxed. You know how it's going to be used, you know what you're looking for, you know what you need to deliver. Abdominal imaging, on the other hand, is very different. It's much more rich, but much more complex as well. The reason why you're doing imaging, abdominal imaging, is extremely diverse, and the things that you're looking for are extremely diverse as well. So now you're looking at one type of imaging, different protocols, different diseases, different users as well. So you need to adapt an algorithm for those different use cases. So the clinical value that you can get out of it is potentially enormous, but it's much more complex to do it properly.
Thank you for your perspectives. So following up on this discussion, and please react to this statement, but most of the use cases that we have in other parts of the body, they are flashy, or in other words, sexy to decision makers, even the ones outside of medicine. But one thing that all abdominal imagers know is that there are a lot, probably with no comparison in other body parts of low value and burnout generating tasks in reading abdominal images. And it's like you're a politician and you're promising that you're going to improve the plumbing of a city. Nobody's going to vote for you because of plumbing, right? But as an abdominal imager, if you promise me that I don't have to count a renal cyst or measure a renal cyst again, and I can focus on that cancer that you are trying to characterize on my behalf, I mean, if you solve the simple low value and burnout generating tasks first, maybe there's a way to incorporate value for abdominal imaging. But how do you react, and how do you see the industry trying to solve the things that are boring yet simple, but not flashy to the decisors, but they are probably to be the more meaningful ones?
That's a super interesting question. I think it's a complex question. I think the answer will lie in the collaboration of many different actors. Compared to emergency department, where you usually have kind of like fewer decision makers, in abdominal imaging you will have many different specialties involved. So if we take oncology, for example, you will have to take on board the radiologist plus the oncologist plus many different decision makers, basically. So you have to take into account all of this. Another thing that will be really important is that as AI vendors, I would say, we only have control over a definite amount of things. We do not have control, for example, about data sharing, access to patient data over time. For example, if we're you do, you're lucky. So I think the revolution in abdominal imaging will really be enabled by many different actors working together towards this goal. And when I say many different actors, it's also insurance, but also the PACs, the data companies, sometimes governments. Like in France, for example, we have a new initiative where patients can opt in to share the data at a national level, which will massively help, especially for oncology follow-up, for example. So yeah, it will require the collaboration of medical actors, government actors, and industry to solve the issue at many different levels.
I completely agree with everything Fanny said. I'm maybe going to answer this question at a slightly different angle, because that was very well covered in terms of decision makers and stakeholders. For me, I think what I've noticed in the conversations I had, I used to work in the NHS in the UK, so I was kind of on the other side of this as well in terms of decision making to an extent. There's almost an exhaustion in the market now of people have been overpromised what AI can deliver, especially in the lung space and the breast space. It's not to say they don't have value, but people are starting to get a little bit tired of the same old offerings and the same old suggestions and the same old, pitches and taglines, whatever. What I'm finding, and especially with the conversations that we've had, Leo, but also with many others, is they're saying, look, at the end of the day, I just want something to make my life better and easier. Yeah. I just want to not feel exhausted doing my job. I want to prevent burnout. We don't have enough radiologists. I just want stuff that can help me do that and automate the part of the job that's actually not necessarily that important, because what's important is the decision, it's the diagnosis, it's getting the results back to the patient. In the UK, for example, you're supposed to have at most a 4-week turnaround of a scan. Like, you have a scan and you've got 4 to 6 weeks where you need to get that oncology result back. Patients are finding that they're not getting these results back quick enough. There's a significant issue there, and that's actually a global problem. So how do you resolve this? Well, you solve it with AI solutions that can churn out those results, prevent that burnout, and ultimately get those results back to the patients and the decision makers, which is, the oncologists and the surgeons. That's where abdominal AI has a significant opportunity, because it's not really, you said it very well. It's not the big flashy stuff. It's not the stuff with that's gonna shine like the sun. It's the stuff it's the piping, as you described it. It's the stuff that you just need for things to function. Yeah. And it doesn't even have to be looking at primary disease. With the liver AI can be useful for a multitude of reasons. Whether it's oncology use cases or whether you're looking for cirrhosis, it might be for liver mets. It might not even be for primary disease. There's so many reasons why abdominal AI is a huge opportunity to actually just help the workload, help with the workflow, and ultimately that is what the decision makers want. They say like, well, if the economics make sense, if the patient outcome measures are improved, it's almost a no-brainer. And I think that's actually going to be a really big difference between abdominal models and what we've seen with AI to date in some of the other specialty areas.
And since we're also discussing value, right, what works, what doesn't work, now it's time for all of you to shine. Can you give me clear examples from your own portfolios of solutions that you think that are able to solve today some of those hurdles, some of those concerns, and that can have some measurable value from the standpoint of the poor radiologists reading those scans?
And you're the radiologist, you should answer. I think there are different levels. I would say incidental findings of septal findings is still a big case because abdominal studies, they have many slices, there are different windowing, and yes, you're supposed to review everything. In the reality, you review as much as you can review in the time that you have and in what you're looking for. So yeah, overseeing something is gonna happen. So incidental study is a big thing. And then the second one is everything around workflow efficacy. So basically pointing a radiologist to what they should look at in what window and where, and then potentially automating measurements, follow-ups. That's a big one as well.
Yeah, I guess it's time to pitch almost, right?
Yeah.
So yeah, I mean, everything Fanny said is true, and I think what Better Medicine is working on is very aligned to what was said there. So we have brought to the world the first clinically validated CE mark, not yet FDA approved, kidney cancer solution for kidney lesion detection. So this is looking at benign and malignant lesions in the kidney. Why is this important? Well, kidney cancer is a really, really good example of a sort of underserved cancer in the AI space, but in particular, most kidney cancers are found incidentally, or at least more than 50-60% are found incidentally. You're not even looking for them when you find them. And you miss them. You miss them frequently. There's a lot of publications out there showing high frequency of kidney cancer that is missed. Not just once, but actually on several occasions. So what this shows, I mean, if we think about the kidney cancer use case and then expand it out to other abdominal models in oncology workflows, for example, you have this tool that's acting as a safety net tool and almost a guide to say, look, there is something there. You need to know that it's there, and you can decide what you want to do with it. In the first instance, incidental findings, opportunistic screening. I think that's where the abdomen's really, really going to shine compared to some of the other models. Then, of course, categorization comes into play. Okay, is it malignant? Is it benign? That's almost like the secondary benefit to this. And then the decision has to be made by yourself, Leo, for example, as a radiologist. So I think our kidney cancer model is a really, really good example of what we can do in the abdomen. We're going to expand this into sort of liver, pancreas, spleen, all very, very similar opportunities there. And at the end of the day, if you don't find these lesions soon enough, the disease progresses. In fact, there's been quite a few instances with kidney cancer when I looked at the research where at the point of diagnosis to the point where it was first present were 2 years apart. They went back and they found that a stage 4 kidney cancer was actually stage 1 cancer 2 years before. This is where we need AI to help us. That should be a never event, right? And it's not because the radiologists aren't doing their job well, like they're overworked. Some of these things are just quite literally just difficult to see. So this is where we come in as a company. This is where I think the opportunity for others as well to work with us comes in. So we can actually work together to make sure that's a never event. Not just for oncology, of course, but for other conditions as well. And I'll leave it at that, I think.
I guess I can only agree, and I can give a few more specific examples as well. So yeah, exactly as you said, in incidental findings, you're able to detect cancer much, much earlier. So for example, we just released an algorithm for pancreas cancer. It's known to be one of the most deadliest cancer in the world, and it's usually detected when it's bigger than 2 centimeters. Basically, usually you're not eligible for surgery at that time, and the survival rate is really low. It's less than 10%. When you catch it when it's lower than 2 centimeters, the the 5-year survival rate is much, much better. And we have shown in many studies that you can actually see that in the images earlier. It's just really hard with a naked eye when you're not specifically looking for something, and the incidence is really low. So you can't blame radiologists for not finding that. So that's kind of a very precise example on incidental. And on the older workflow, the other solution that we're developing is detecting lesions for now in the bone, the liver, and the pancreas, very soon in any organ in the abdomen on a thorax, abdomen, pelvis scan. And what it does, automatically detects segments and follow-up over time, and it can do an automatic assist, which is really time-consuming. And sometimes not even done because it's too time-consuming. That's a specific example.
Thank you both for the great examples. They definitely add value to the radiologist. But I've been so far talking about value from the standpoint and perspective of a radiologist, but value can be perceived in different ways by the different actors. And at the end of the day, the adoption of an AI solution goes through the CFO, goes through directors and other people with different susceptibilities, right? So how do you and your companies view what constitutes value in clinical adoption of AI in the most comprehensive way, right? And at the end of the day, how do you get to the show me the money moment? And how do you get to define who pays for AI? So this is a compounded question, but feel free to answer however you feel.
Yeah, I'll start with that. I think realistically, you have to think of this almost like as a health economic based type study in a way. In a real world evaluation setting, you can claim whatever you want, accuracy, specificity, sensitivity of an AI model, which is great. That'll get you a seat at the table. But the truth is if it doesn't have any impact on workflow, positive impacts on workflow, it's irrelevant. Those accuracy data points, it means nothing if it doesn't have an impact there. So you kind of have to do this in stages. And there's an opportunity here to almost combine, world-leading research with real-world implementation. In the UK, we've called this research for patient benefit as an example. There's lots of funding to do that. But realistically, what you're doing is you're saying, okay, if we implement this prospectively, not retrospectively, but prospectively, in real time, in service, what impact is it having? What downstream effects is it having? Or upstream effects is it having? This is where actually a full health economic study is really, really valuable, because it's not just looking at where the technology is embedded. It's looking at, well, what impact does it have on the wider MDT? What impact does it have in terms of the person being referred in? So, yeah, fair enough, the user may be the radiologist, but actually the people who ultimately benefit from it may actually be the people downstream of it. It may be the oncologist. It most certainly should be the patient, you would hope. All of these things add together. It doesn't really matter where you are in the world, to a value proposition that makes sense for a CFO to turn around and say, okay, well, I can see how this saved me money, it saved me time, there's efficiency gains, but ultimately also the patients are better off for it. It becomes a no-brainer. But what you're really realistically doing is you're developing a business case for a hospital. And by doing these studies, they might be 6 months, 12-month studies, depends on the incidence rate, I suppose. You're giving that evidence to say, there is a business case to do this, to procure it, to purchase it, to work with insurers to get it. So that's my view on this.
I completely agree with what you just said. So basically, I think the short answer is depends who benefits from it. At the end of the day, the financials are always going to make the decision, but the stakeholders and the influencers are not the same person. So for each algorithm or each solution, each product, you have to really truly identify who is it beneficial to. It can be the hospital system if it's about productivity or quality. It can be insurance if it's about preventing a very expensive treatment in the end. It can be patient if it's something about like extra care or peace of mind. And it can be the radiologist if it's about quality, peace of mind, comfort at work. Based on those different personas, as we say in the industry, you will clearly identify what you're bringing to them. And then you need, based on that, to build their business case with them, obviously, and then to present that together with the CFO. You clearly have to identify the beneficial person and then come together to make your case.
That got me a lot of thinking, because both of you, and I probably have to diverge a bit from Abdominal and go back to clinical AI adoption, but both of you mentioning business case and health economics, and I'm full supporter of that too. But that raises the question, people don't do the same legwork to buy an MRI scanner, right? Or to buy a new PACS. You have to build a business case which is correct, right, within your business. And you have more standardization of elements to empower that decision. Maybe one of the problems of clinical AI adoption is that every single one is like a drug medication, right? That requires its individual study for its individual partner, for its individual scenario. And there's not a way to standardize and throw in the same box all the variables that are relevant for each of the players that are considering adopting. How do we solve this, right? Because we want faster, easier clinical AI adoption, but at the same time, the decisors and the industry, we don't have all the answers, and everything has to become a study, right? So what is your view on this conundrum, and what are possible ways for us to create more standards and more easy decision-making, instead of deciding, should we adopt AI, much more like, which vendor should we adopt, or which solution for that use case, right?
Well, you just said it. At least we've switched in the last, I would say, 5-6 years from do I need AI to what AI do I need, which is a massive shift. I began in AI 10 years ago. It was not the same space. So that's the first great thing. Then I think we're in the normal curve of innovation and adoption. You start with a completely new technology that will revolutionize healthcare. And because it's a revolution, small actors have to do it, because small actors are agile, they can iterate really quickly, and it's not too disruptive to their workflow. We're now in the phase where those actors are becoming to consolidate really strongly for many reasons. Financial reasons, you can't make a business case on one use case, I would just say. And second reason is that you need to serve an organization, not one user. And so you have to consolidate. So I think the role that hospitals and medical professionals can play in that is to really be super clear about the whole needs. When seeing people from the industry, it's not specifically like what I'm doing right now in, I would say, liver imaging, but kind of like opening the conversation to what my department needs and what the oncologist I'm working with needs, and what the surgery needs, just so we can think bigger and anticipate the needs. And then on the other hand, I would say that it's the normal flow, and hospitals will just see it happening with the consolidation platform where is a really good interim situation. I think at the end we'll have platforms for consolidating smaller algorithms, but also bigger institution having a holistic approach. And then I think it will be up to the facility to decide, do I want one vendor for everything, but I can't really choose what I need? Or do I want kind of like an Apple store where I can choose exactly what I need? Which is great, but requires also more skills in-house to be able to make a choice.
I guess, Leo, the way I'd look at this is the difference between buying a scanner, that what people have been doing for decades, is a combination of trust. People just trust that those things work now, and what people are accustomed to. AI is new. It's a buzz phrase in many ways, actually. Like, what is artificial intelligence? We could have a whole panel on that concept, really. But at the end of the day, people just aren't used to it yet. They don't trust it. So therefore, you need to evidence it so much more than you do almost any other type of technology. In some ways, that seems unfair, to be fair, but that is kind of how it is for now. Maybe in another 5-10 years, that won't be the case, because people are they know what they're looking for, they're used to it, they become accustomed to it, and they will trust it. In the meantime, I suppose, we're at the CARPL booth, right? So platforms have an opportunity to help with this. If you have a trusted vendor that is a platform as an intermediary, that helps, particularly if you've built really strong post-market surveillance into your system. I think that's a nice middle ground. At the end of the day, this also gives you kind of a plug-and-play, switch-on, switch-off opportunity as well. So you're not really locked into something that eventually doesn't really prove its value. So yeah, maybe you can start off with some of these lung solutions, breast solutions, kidney solutions, pancreatic solutions. If it's not working for you, you simply just don't stop using it. You know, that's it. You just then use the other AIs that do work for you. Obviously, a really interesting case. ContextFlow recently got approved for reimbursement in Germany, the first ever AI to be reimbursed in that market. That's another example of where trust can be built. Like when you eventually get so much evidence, you become a trusted vendor, you can actually be fully reimbursed. We will start to see that. I think certain vendors will disappear in that process, but the ones that truly make it are the ones that are going to succeed, and they're the ones that will be the trusted entities. They'll be the Siemens and the Fujifilms of the AI industry. I think it is a matter of time. But right now, we've really got to do legwork. We've got to build that trust. We've got to show that this isn't just a buzzword, that it actually brings value. And we will get there. It's just the same with any new technological revolution.
Thank you both. And that was a perfect segue to the next topic, which is you brought up the idea of platforms as one of the ways to consolidate trust or to reduce the variables, right, in this pathway. And in that sense, going back to abdominal imaging, when you look at the abdomen, numbers of the organs times numbers of findings times numbers of diseases and times numbers of disease states, right? So the complexity in abdominal imaging is way higher than anywhere else in the body. And if we are thinking then, hey, better medicine is going to solve for kidney cancer, Intrasense is going to solve for lesion tracking, lesion measurement, right? And then vendor A, B, or C is going to solve for adrenal and then spleen and then whatever. The management of that multiplicity of vendors times findings times use cases and sometimes in the same organ doing the same thing can become chaotic. So in your view, what is the role for a platform in orchestrating that? And if that would be the optimal way to do it. But also as a vendor, how do you see the risks and benefits of the vendor providing limited use cases inside a platform and integrated in a grander scheme of things? So let's discuss platforms, right?
This is it's a very interesting topic, really. I mean, the way I look at platforms and why they're probably more desired methods with a lot of hospitals is the AI vendor itself is kind of in the background. You don't necessarily know that you're using Better Medicine's solution. You don't necessarily know that you're using Intrasense's solution. It's just formed part of your workflow. It's there. It's functioning. The nice thing about platforms, especially when they get more and more solutions within their OS, is that you take a scan, MRI, CT scan, and then all of these things happen at once. So it's ideally, you're running all these different AI models at the same time. You're getting all the answers that you need, what you're looking for, in a singular manner, single workflow. The complexity of the abdomen is very, very true. At the end of the day, if you're just provided with all the information that you need and you can switch it on and switch it off, that really, really helps. When you're a single vendor, it's kind of, especially if you have a single organ-based solution, which is where a lot of us start, to be fair. We have to start somewhere. It's kind of like, well, I mean, that's great for this, but I actually have so much more. I have so much more work to do than just what you're showing me here in the kidney or in the liver. Platforms really, really help you to overcome that problem because you just got to get all of it at once, especially as they onboard more and more vendors. The risk, of course, though, is because you are reliant on two different parties. So if there is an issue at the vendor level where the model performance drops or ultimately there are issues or bugs in the system, then you have two layers where things can go wrong. And I think you have the platform itself could go wrong, which is probably the worst case scenario, but then individual algorithms may also have issues. So there is a risk there, and then you have to then work probably through the platform to go back to the vendor to fix that problem. So it's not like you have that direct relationship. So there is some risk there. you can mitigate it to an extent, but I think it's something that I think hospitals really have to get accustomed to, is the fact that it is a good solution for now to get everything that you need, but it does come with some risks, and you need to assess those risks versus reward. And my opinion is that the reward of using platforms and all these solutions is most likely greater than the risk of a singular solution failing on a singular day.
Yeah, I echo what you just said. I think it's especially interesting in the interim to really make a holistic experience and have, but making feel like it's one product. It can also play a role in reporting, for example. The advantage of platform is that you have access to the whole picture of the problem of the hospital. So you're able to kind of be the pilot directing image 1 to algorithm 1, image 2 to algorithm 2, and helping them kind of mitigating this risk that you're mentioning with the engineering behind that, the plumbing behind that. And then downstream, you're able to consolidate all the results into something that actually makes sense and look and feel like one product. So I think that's really the value of it. It's especially interesting for findings where you don't need interaction with results, because that's, I guess, the limitation of the platforms for much deeper workflow at the moment. I'm sure it's going to evolve in a way that is going to be possible at some point. But yeah, I would say kind of like putting the glue between the algorithm and making sure that it solves the bigger problem, from the plumbing to the reporting.
Great insights. We're gearing towards the end now. So like a flash round, one thing we should be doing more in Abdominal AI, and one thing we should stop doing in Abdominal AI, thinking about the next 5 years. Time to pitch again.
Yeah, I've mentioned it a few times. I think with Abdominal AI, we need to think a little bit differently to how we've thought about sort of the lung screening. I mean, there's less screening, essentially no screening that I'm aware of when it comes to the abdomen. So the context is different. Lung screening, breast screening, prostate screening programs are going to have a very different use case to what we're talking about here. So for me, it really goes back to that opportunistic screening. It goes to the fact that you can miss stuff. The complexity of the abdomen means that missing things is more likely. You need something to really, really help you. And it needs to be looking at the stuff that you're not looking at. If you're looking at the liver, don't you like the idea of having a companion who's also looking at your kidney? Don't you like the idea of a companion that's also looking at the pancreas and telling you, like, oh, there is something over here? So that your field of view doesn't necessarily matter so much as it does having all of the AI solutions there to help you navigate around it. And it draws your attention to where you need to go. So I think that's a really good opportunity for the abdomen. In terms of what we shouldn't do with the abdomen, I don't know. I think we need to be careful about characterization. My view on this is, I'd love to see your pancreas solution because that's so complex. And I've seen some really interesting research at some conferences that I've been to where they're really going into the nitty-gritty of characterizing pancreatic lesions. At the end of the day, if an AI makes the wrong decision on what something is, and it tells you something's benign when it's not, or it makes you change your decision on what something is, that can have some pretty negative, maybe even devastating consequences. So I think we have to be careful and understand the difference between detection, characterization, when it comes to abdominal AI. And if eventually, I think AI will be really, really good at the characterization piece. I actually don't think we're there yet, personally. I think we're getting there, but I would trust a trained radiologist to characterize something better than I would most AI models today. I think that's fair to say, but actually finding the stuff in the first place is actually what's important. And then you've got the rest of the workflow to help you with the rest of it. So we have to be careful. I'm not saying we should stop or avoid it, because I think you used the word avoid when you asked. I don't think we should avoid characterization, but I think we should be careful not to overpromise what it does.
Completely agree with that. I guess what we should do way more is retrospective and prospective studies at hospitals level to kind of stop being blind about what actually happens and really open the discussion around how could we work differently, which leads me to the second point: stop doing, but it's also a start doing. Stop thinking that abdominal AI is going to be applied exactly as we do medicine today, and start thinking as it come with kind of a revolution of how we read abdominal AI. The way we do it right now is limited by human factors and what we can do in a 2D image, one 2D image at a time with hands. The revolution in AI in abdominal is much bigger than any other imaging, and it opens possibilities that are truly different and will lead to the radiologist working differently. So kind of stop thinking that, oh, it's a plug and play, I will do exactly the same, but really educate around it's actually changing the way you're doing right now in a good way, but you'll have to train them, accompany them on how to behave differently, and ultimately being way more efficient and having a really high quality reads.
Thank you. That's a great insight. We should rethink the way we read abdominal imaging in general. Now nearing the end, your closing remarks, if you would like to leave something for the audience too. And I would like again to thank you for your participation and thank CARPL for the invitation. And I'll leave it to your closing remarks.
Thank you so much for having us. It was a really insightful discussion. My closing remark is if you want to talk oncology AI follow-up, please come see us. We're at the Gerbe booth, right behind United Imaging. Please feel free to reach out as well. I'm on LinkedIn, or please contact CARPL and they will give you my contact details. We're always looking for partners to evaluate the value that we're building, radiologists to kind of like play table tennis with ideas and try to really understand what brings value. So we're always really happy to build this community and expand. So please reach out if you're interested.
Thank you. Yeah, the talk's been brilliant, and it's a topic that needs to be discussed more. I think there's a lot more to discuss in this space. I think we should really focus a lot more on what we can do in the abdomen. Our location is literally next to the CARPL booth. So if you find CARPL, you'll find us. We're also a similar color green, ever so slightly brighter so you can see us. And we'd love to talk to you about opportunities that of some of the other solutions we're working on as well. I focus specifically on our kidney solutions, but we also build resistant segmentation solutions, longitudinal tumor tracking. It would be great to discuss that. In terms of closing remarks, though, on the topic of the subject matter, I think we need to start increasing our field of view when we're thinking about AI. We've had tunnel vision for too long now. We've thought for so long about, I'm in the chest, I want to do this. I want to look at this one organ, I want to do this. We need to move away from tunnel vision. We need to broaden our perspectives and think what the art of the possible is. We need to work with our medical professionals to understand what that is. And then we need to bring the AI guys out of the back room, bring them into the front, and actually be having the conversations that I'm having with like yourself, Leo, and others. They need to be part of those conversations more directly. And I think the only way we're actually going to improve on this is to actually bring everyone together, probably academically to begin with, to have those debates, those discussions, so we can think much broader than we are today. And I'm actually looking forward to when that happens.
Thank you so much. Thank you, and thank you the audience too.